Hi all, welcome back to Dr. Whiteboard Talks, daily dose of MCQ. Today's question number 1. A 70-year-old man presented accompanied by his wife who stated that her husband had lost all interest in life. So, what would support a diagnosis of dementia rather than a depressive disorder? So, this is the question. So, this patient is a 70-year-old man. So, the question is to support a diagnosis of dementia. First one is agitation. Second one is complaint of poor memory. Third one, impaired short-term memory. The fourth one is loss of libido. And fifth one is option E, urinary incontinence. So the answer for this question is option E, urinary incontinence. This is because while we rule out other options, we have the patient with who has a complaint of poor memory. So the poor memory of a patient would more common be in depression. So that is not pointing to dementia. Okay. And that is a subjective complaint, whereas an objective finding like poor short-term memory will be more common in dementia. So here we have poor memory, which is a subjective complaint, is more common with depression. The second option, like agitation, can occur in both. So agitation can be there in both. Loss of libido is common in depression than in dementia. So the answer is urinary incontinence. So we have poor short-term memory is more common in dementia, whereas we have poor memory as a subjective complaint is more on depression. So the only one answer is urinary incontinence, which is very rare in depression. So urinary incontinence is very rare in depression, but can occur in dementia, especially as it advances. So as it advances, the dementia advances, there is a chance of urinary incontinence, and the reason for this is normal pressure hydrocephalus. So the answer for the question number 1 is we have to rule out complaint of poor memory, we have ruled out impaired short-term memory, we have ruled out, and loss of libido we have ruled out, agitation is also ruled out, and the answer is urinary incontinence. So agitation can occur in both, as well as the poor memory. As we said here, the complaint of poor memory is more in depression, whereas the impaired short-term memory is more common in dementia, but it is an objective finding. Okay. And we have loss of libido more common in depression, and urinary continence is very rare in depression. So there is no chance of urinary incontinence, we can say, in depression. We don't choose the answer poor short-term memory because in the impaired short-term memory there can be a overlapping of memory loss in both depression as well as dementia. That means the complaint of poor memory can be subjective. So the option for the best answer is urinary incontinence. Now, coming to the second question, a 48-year-old man was admitted to the emergency department with 2-hour history of hemoptysis. Okay, so there is a case with history of hemoptysis, and she had been treated for pulmonary tuberculosis 30 years ago. So the age of the patient is 48 years right now, and 30 years ago, 30 years, at 30 years of old age, she was diagnosed with and treated for the case of pulmonary tuberculosis. And when there developed a right upper lobe cavitation which contained aspergilloma. So it was later developed into an aspergilloma. So she continued to cough up large amounts of blood. So coughed up large amount of blood over the next 24 hours, and the decision was made now to embolize. So the radiologically guided embolization was planned for this patient. So what question is, what is the artery of target for embolization? So the target of embolization is the question. So we have option A, brachiocephalic artery. Option B, we have bronchial artery. Option C, we have intercostal artery. Option D, internal thoracic artery. And option E, pulmonary artery. So the answer for this question is an artery which is planned for target for embolization. Case of 2-hour history of hemoptysis, large amount of blood over next 24 hours was coughing up. So 2-hour history of hemoptysis followed by coughing up of large amount of blood. So for the treatment to start with, we have to embolize the artery of bleeding. So there is a history of tuberculosis in the age of 30 years, and there is a right upper lobe cavity which contain aspergilloma. So for our question, the answer is bronchial artery. The reason for that is most frequent diseases causing hemoptysis are some of the diseases, like most commonly which we see which cause hemoptysis, are bronchiectasis, tuberculosis, fungal infections, and cancer. So causes of bleeding from large vessel. So this history given in the question suggests that the bleeding is from a large vessel. So the large vessel bleeding can be with infections, cardiovascular, congenital, neoplastic, and vasculitic diseases. Okay, so in case of severe hemoptysis requiring treatment, so in case if you want a treatment to be done in a case of severe hemoptysis, the source of bleeding originated is most likely to be bronchial. So the answer is bronchial artery, which is 90%, and second comes to 5% of cases can be pulmonary artery. So the majority, like 90% of bleeding, which is large amount, is from bronchial artery. Okay, so the question was, again, just to sum up, there was a bleeding which suggests a large amount of copious blood was vomited, plus there is a 2-hour history of hemoptysis, and we have the options of target embolization of the artery, and the answer is bronchial artery because it is 90% or 95% it is from bronchial artery. Now coming to the third question of today's daily dose of MCQ. A 32-year-old man returned from a holiday in a Mediterranean area with sundan and numerous hyperpigmented, slightly scaly lesions on the neck and upper trunk. So in such cases, you have to note that the patient presented with scaly lesion on neck and upper trunk. Okay, the position of the lesion should be clear. So neck and upper trunk, these are slightly scaly. Okay, plus hyperpigmented. So the points to be noted here are: one is the patient has hyperpigmented lesion, plus there is the area of slightly scaly lesion on neck and upper trunk. So the patient is 32-year-old woman. So she mentioned that same areas she had a fawn colored in months before her holiday, and these areas of skin had failed to tan during her time in Mediterranean. So she was in a holiday trip. So before she was going for the trip, there had a fawn colored discoloration in the same area where now she developed a hyperpigmented, slightly scaly lesions on the neck and upper trunk. So what is the most likely diagnosis? So the question here is asking for the diagnosis. So we have the options: chronic plaque psoriasis, discoid eczema, pityriasis rosaceae, pityriasis versicolor, and seborrheic dermatitis. So the question's answer comes here is option D, pityriasis versicolor. So why we have to rule out other options, plus what is the reason why we say this is pityriasis versicolor? So this question, if we typically see, this is affected in the neck and upper trunk. So this neck and upper trunk lesions, which before it was beige or fawn colored on an untanned skin. Untanned skin means there is no sun exposure. Before it was beige or fawn colored. Later, these areas become hypopigmented. So become hypopigmented on patient's skin, and when it is tanned, other areas are tanned following a sun exposure. So once the patient had a sun exposure, the area became hypopigmented and the other rest of the body areas in the skin became tanned. This typically points towards pityriasis versicolor. So this is the characteristic of pityriasis versicolor. To rule out other options, in case of psoriasis and eczema, we have sun exposure can improve, actually improve, can improve some of the skin diseases. In such cases, we have psoriasis and eczema, and this may result in hypopigmented areas at the site of previous lesion in some cases, but one would expect a history of lesion at other sites, for example, upper. So, this can also be like, we should also focus on where the site of the lesion. So, if it is eczema or psoriasis, there can be other sites also, like upper and lower extremities can be there as well as on the trunk, but in this case, we have neck and upper trunk. So this more pointed towards pityriasis versicolor in that way. But we should think here that hypopigmented areas at the site of previous lesion, in some cases, okay, it can cause like that, like hypopigmented areas. But there the site is the one which we rule out psoriasis and eczema. Now, seborrheic dermatitis is a common cause of dandruff and consists of erythematous scaly. So the scaly lesion is erythematous scaly macular lesion affecting the scalp mainly, eyebrows, nasolabial folds, as well as less frequently in the center of the chest. So presternal radius and all, this is very less frequently. So that we rule out seborrheic dermatitis. Okay. Now the next option is pityriasis rosaceae. So this affects the trunk and the limbs mainly. So here in our question it was neck and the trunk, upper trunk. So pityriasis rosaceae, trunk and the limbs are mostly affected, and there will be a patch called herald patch. Herald patch. In this herald patch, this is a single patch followed by 1 to 2 weeks later more generalized erythematous. So after 1 to 2 weeks, first it comes as an herald patch, as a single patch, and later 1 to 2 weeks later more generalized erythematous scaly patches on the trunk and upper limbs can be developed and slowly spread towards the thighs and subsequently fade over, and then later it fade over next 6 to 8 weeks. So coming to our question, we have ruled out other options, and the options more pointing towards the given scenario is pityriasis versicolor. So the option for this question is, we have pityriasis versicolor. Okay, so that was the three questions for today we discussed. So once again, when we come to the topic backwards, one was the pityriasis versicolor, this case, and the second case was about target embolization artery when a copious amount of blood was vomited by a patient, and this is actually hemoptysis, like coughing up of the blood, 2 hours of history. So there, which was the artery, and the option for this question was bronchial artery. And the next question, the first question of today's round, was that where a patient came with his wife, stated that like he lost all the interest in life, and we were asked to support a diagnosis of dementia. So the agitation was present in both of the cases, so we ruled out that poor memory is more suggestive of depression, so we rule out that. And impaired short-term memory actually is a objective finding seen in dementia, but there is a overlap can be there, as there is a memory loss of libido is not seen in dementia. So in that case we rule out loss of libido also. So the correct answer for this question becomes urinary incontinence. Why? Because urinary incontinence, because it is very rare in the case of, it is very rare in the case of depression, but can be there in dementia. As the age advances, it becomes more prominent due to normal pressure hydrocephalus. So thank you for watching. Shall see with the next couple of questions in a later video.